Yeah, I hope I can find this. It's very, very tiny here. Okay, there it is. So, ladies and gentlemen, dear colleagues, Professor Berger, thank you for the invitation. I've been attending this symposium since a couple of years as an adult cardiologist, and I never thought of being a speaker here, so thanks again. And I'm also grateful to the previous speakers because they have given us a lot of important information about TAVI, and I can refer to it, and I hope there's not so much redundancy in my talk. So I thought, well, that's quite a huge topic, and there's nothing else going on in adult cardiology that is bigger than TAVI, to be honest. And where to start, and how can I approach this? And you think about your own patients in your institution, and I'm going to show you some of them. And you recognize, okay, that there are not so many patients with true congenital heart disease and TAVR that we have been treating since now. But I think no one can claim to have treated real CHD patients with TAVI on a large scale today. So I looked into the literature, and it was quite interesting to see that pulmonary valve implantations in context with congenital heart disease is more prominent than congenital aortic valve implantations. And most of the papers are related to bicuspid aortic valve. But I think it's clear that this is the most common congenital heart defect that has affected TAVI for years now. We have seen a little bit of this before, but let's not just think about the bicuspid aortic valve, because there are other patients that we have to deal with, and there are around 500 patients, newborn patients a year in Germany that show up with congenital aortic valve stenosis. So that's quite a small number, but it's very important to care about them. And it's also very important to keep in mind that around 1/3 of them may have associated defects that affect also the risk and the complexity of the procedures and operations. So why is there a need for new therapies? The surgeons do a fantastic job, we know that. But it's also a fact that complex CHD patients carry higher risk undergoing aortic valve operations. And of course, there are many reasons for prognosis that is worse than for patients with isolated aortic valve therapy. But these particular risks are really a very good reason to go on and to expand our armamentarium, not least for the cases where there might be a prohibitive risk for repeated surgery. As in this case, this is one of our 20-year-old patients with a hostile chest and very difficult to go for reoperation. It's clear that aortic valve treatment in adults is different from patients during childhood, where balloon valvuloplasty is a life-saving therapy, of course, but it has to be considered a palliative therapy. The adult patients present with degenerative aortic valves that cannot be ballooned again or reconstructed, so these patients sooner or later need a new valve. More or less, all these patients present with some degree between stenosis and regurgitation. And either they show up with their own valve, which has been ballooned or reconstructed, or they have already undergone some kind of replacement, either with a bioprosthesis, a mechanical valve, homograft, xenograft, and some of them might already come up with a problem of patient prosthesis mismatch, which is really a problem in the long term. But of course, the vast majority of patients will have bicuspid aortic valve pathology and related disorders. So I just want to show you one of our patients, 41-year-old male, coarctation bicuspid aortic valve and aneurysm in his history and medical history. He was operated relatively late in life. At 16 years for the correction of the coarctation. 2 years later, he got a homograft, aortic homograft, and then this homograft did its work for more than 20 years, which is quite remarkable. But we haven't seen this patient a couple of years. He was lost to follow-up. And one day he showed up in a really bad shape after endocarditis of this homograft, and the hemodynamic data were quite catastrophic, as can be seen here. Highly elevated antiastolic pressure, pulmonary hypertension, low cardiac output, and so on. And it was imminent that this patient needed urgent treatment for this regurgitation. So we went into a hard team discussion with our surgeons, and they were not really enthusiastic about the idea of explanting this complete calcified homograft due to the adhesions with the surrounding structures, and also the replanted coronaries were quite difficult to detach from these adhesions. It was also discussed whether it's possible to place simply another valve in this calcified homograft, but the sutures would probably be difficult in this case. So we evaluated him for transcatheter aortic valve implantation. We've seen these excess images from CT scan, which was not an issue in this patient. Then it's very important to measure the level of the annulus or the site of implantation, which was not that easy in this case. You have to keep in mind that these valves are designed for stenosis, not for regurgitation, and this was a pure regurgitation patient, so we chose a 29 millimeter valve with a little bit of oversizing for the homograft. So that's the situation in the cath lab. We can see this heavily calcified homograft. I hope you can see it. It's quite a little bright here. We also used a gentle balloon valvuloplasty, not for relieving a stenosis, of course, but for verification of the valve size. This is somewhat important if you're not absolutely sure. And you can also visualize the localization of the narrowest part for planning the implantation. Crossing the isthmus was not an issue with this catheter, and then we came up to the implantation. Those of you who are familiar with TAVI, you might feel a little bit of discomfort. That's quite understandable. That's what I felt during the inflation. We can see that the implantation was quite low in the LVOT, not as we intended, and the valve didn't expand as much as I intended as well, but we could post-dilate it, and the hemodynamic result finally is okay, but you can see here it's quite down low in the LVOT, which usually we want to do it like that. But not everything is perfect we're doing. So finally, on echo, it's a reasonable result. No PVL, the mean gradient was good. We were lucky we didn't have any changes in the conduction, and the NT-proBNP levels went down to normal during follow-up. So despite all the enthusiasm for TAVI, we must face the fact that there are still many unresolved issues that cannot be addressed all here. Some of them have been already mentioned. But of course, they are also relevant for the ACHD patients, which are probably younger. I just want to highlight some of them. We have heard about the durability of the transcatheter heart valves. We now have data around 8 years, but we have to keep in mind that our patients are pretty young, and maybe they will come up and need reinterventions, which is also a problem if you put several valves into another. And it's even more complicated to discuss these data because different THV types have been used, and also different generations have been used, and the PARTNER 2 trial is one of the examples that probably it's important to know what specific valve we are talking about. The longer-term durability data most come from observational studies in typical TAVI cohorts, 80 years old patients, cardiovascular risk factors, and it's unclear whether these data can be easily transferred to our younger patient group. We do have more data on surgical valves over long term, but different criteria for structural deterioration have been used, and it's difficult to transfer these same data to the transcatheter heart valves as well. So bicuspid aortic valve, that's of course a huge topic because there are many patients around there, and the problem is that the most important studies, all the randomized trials, all the industry-driven trials have excluded bicuspid aortic valve in these studies. So simply there's a big gap in evidence that we have to face with. There's one very important study because it elaborated the specific problems with bicuspid aortic valve very well. And it has identified two risk factors that, especially when taken together, represent a considerable increase in procedural risk. That's calcified raphe and excess leaflet calcification. This combination may lead to more PVL, more root rupture and conversion to surgery, and finally also substantially higher mortality. So you have to have good reasons if you want to treat these patients with TAVI today. On the other hand, we have data from huge registries where successful TAVI could be documented. This is true for the balloon expandable and also for the self-expandable valves. But since there are no anatomical data in these registries, it's somewhat difficult because the patients are probably somewhat selected. I want to show you just another patient, a 51-year-old male patient from our center, which is a physician himself, internal medicine. He also had coarctation and repair with a prosthesis at the age of 13. He had really severe arterial hypertension under combined therapy with 5 different drugs. And of course, he had bicuspid aortic valve, which was initially okay. As severe comorbidities, he had this thyroid cancer with liver and bone metastasis, and fortunately, he had some kind of third-line therapy. I don't know these drugs at all, but the disease could be stabilized, so he had a good quality of life. When we have these patients with coarctation repair after several years, we do MRI or, of course, CT scan if necessary. And as you can see here, there's a complete interruption of the aorta at the level of this tube graft he got when he was a child and this massive collaterals. So we took him to the cath lab, and also on direct angiography, there was no residual channel seen, so it was completely occluded. This is why we had to cross this tube to perforate it with some stuff from the CTO guys, but it was not possible to cross this tube with any kind of balloon, even the smallest one, so we had to go for laser angioplasty, which was quite successful. We burned a channel in this fibrous tissue, and afterwards it was possible to stepwise dilate the tube graft and finally put a CP stent in, and we had to put another CP stent in due to the heavy recoil, and had finally a good result. So the patient went home. He could reduce his antihypertensive therapy to 2 drugs, but it didn't take long. Only 2.5 years later, he came back with a severe aortic stenosis now. He was admitted to another hospital with pulmonary edema. And we did our evaluation with the CT and took him to the cath lab again. We post-dilated the CP stents and had no residual gradient. This was just for preparation of the TAVI, of course. And we saw this coronary angiography with a stable one-vessel disease of this diagonal branch that didn't cause any symptoms, so we left it. And then it was not a problem to cross these stents with a TAVI catheter. We implanted the SAPIEN 3 valve, a 29 millimeter valve, with a reasonable result. That's okay. That's a good case. Other cases are more difficult or more questionable. This is one of our patients with a severely calcified raphe and not really excessive, but heavily calcified leaflets. We decided to go for TAVI because this patient refused surgery at all. And you can see one of the specific problems. This valve is not designed to be placed in bicuspid aortic valves, and you can see the oval shape. the immediate hemodynamic result is quite nice. We didn't have any paravalvular leakage in this case, but it's unclear whether this valve lasts as long as in other anatomical situations. So you have to keep these patients under surveillance and look for them for definitely the next couple of years. One other problem that might be, that is quite common with surgical AVR is the patient prosthesis mismatch. It's quite a difficult word, yeah, PPM, okay? Might be detrimental on the long term with worsening of the prognosis. And this is, of course, true for our congenital heart disease patients as well. So this is not an ACHD patient, but the situation might be transferred to our congenital heart disease patients with implanted small bioprosthesis. This patient, quite huge, normal sized. He had already a moderate PPM with his original 21 millimeter perimount valve. It was not the best option for this patient to get this valve in the first place. So the only chance you have in this case is to get more space in this old valve, and you have to fracture it. That's the advantage of the perimount valve, that you can put a high pressure balloon in and crack this valve to gain another 2 millimeters, which is quite enough to achieve good hemodynamics. And we implanted a supraannular TAVR device with a good result, and these are the pressure tracings that we were quite happy about because of this moderate PPM he already had. So this you've seen, this is obviously a great paper, and I recommend it as well because there are a lot of informations in it, also for the facts that we don't have, and it highlights many important aspects that are also true for congenital heart disease patients, even if it's not directly related to this topic. So read it if you like, it's really great. So that's it from me. Thank you for the attention.
Yeah, thank you very much, Dr. Kaleschke. It was excellent. I think we have time for one question from the audience. Yeah, could you elaborate? If no, question from the audience, then one from me, on endocarditis, risk of endocarditis. We see that fairly common, well, would be fairly common in the pulmonary valve. What's your experience with the aortic valve?
First of all, the data, I think, are not quite consistent, but as far as we know now, the endocarditis risk with TAVR valves is pretty much the same as for surgical valves. But you have to keep in mind the original cohort of patients, which are quite sick. And it's very important to, as we do it with the pulmonary valve patients, to send them to the dentist and so on to look for potential sources for endocarditis before the procedure, which is not that easy in the old patients, but we should do it as you probably do it with your pediatric patients.
Okay, so I think we thank you again for your excellent overview. I think we have to move on because of the shortage of time. And I'm happy to introduce Titus Kiene. Titus Kiene is the head of the